Welcome to Quick Medical Review AKT Revision. This detailed session covers asthma diagnosis and management. The major change for current AKT questions is that asthma must be objectively supported and should not be managed with a short-acting beta agonist alone. Asthma is a variable inflammatory airway disease. The characteristic symptoms are wheeze, breathlessness, cough, and chest tightness that vary over time and intensity. They may be worse at night or early morning and triggered by exercise, viral infection, allergens, cold air, smoke, pollution, or work exposure. Variation is central. A patient may have a normal examination and normal lung function between episodes. An expiratory polyphonic wheeze supports asthma, but its absence does not exclude it. Atopy, allergic rhinitis, eczema, or family history increases probability, but is not essential. Ask a structured history. Establish onset, frequency, night waking, activity limitation, seasonal pattern, reliever use, and previous attacks. Ask about hospital or emergency attendance, oral steroid courses, intensive care, smoking, vaping, medicines such as beta blockers and nonsteroidal anti-inflammatory drugs, and practical barriers to inhaler use. For adult onset or unexpectedly poorly controlled disease, ask whether symptoms improve on days away from work, weekends, or holidays. Suspected occupational asthma needs prompt specialist referral while the person is still exposed, because delayed assessment can damage both health and employment evidence. Keep alternatives active. Consider chronic obstructive pulmonary disease, inducible laryngeal obstruction, dysfunctional breathing, heart failure, bronchiectasis, reflux, upper airway cough, pulmonary embolism, and anxiety. In children, consider viral wheeze, foreign body, congenital airway disease, aspiration, and cystic fibrosis. A unilateral wheeze, stridor, clubbing, crackles, failure to thrive, or persistent productive cough is not a routine asthma pattern. The current diagnostic principle is explicit. Do not confirm asthma without a suggestive history and a supporting objective test. Until then, code suspected asthma. If the patient is acutely unwell, treat immediately. Tests can be obtained before treatment only when this causes no delay. Inhaled corticosteroids can normalize FeNO and spirometry, so interpret later testing carefully. For an adult with a suggestive history, measure either the blood eosinophil count or fractional exhaled nitric oxide, called FeNO. Diagnose asthma when eosinophils are above the laboratory reference range, or FeNO is at least 50 parts per billion. If that does not confirm asthma, perform spirometry with bronchodilator reversibility. The test supports asthma when forced expiratory volume in 1 second, called FEV1, rises by at least 12% and at least 200 milliliters after bronchodilator, or rises by at least 10% of the predicted normal FEV1. If spirometry is unavailable or delayed, record peak expiratory flow twice daily for 2 weeks. Variability of at least 20% supports asthma. If eosinophils, FeNO, reversibility, and peak flow variability do not confirm the diagnosis but clinical suspicion remains, refer for a bronchial challenge test. Children aged 5 to 16 use an age-specific objective pathway. FeNO is particularly important and interpretation differs from adults. Children under 5 usually cannot complete reliable objective testing. Treat pragmatically, review regularly, and attempt objective tests when they reach 5. If testing remains impossible, retry every 6 to 12 months. Now chronic treatment. The central safety rule is never prescribe a short-acting beta-2 agonist or SABA without concomitant inhaled corticosteroid protection. Blue inhaler-only treatment does not address airway inflammation and is no longer an acceptable routine answer for confirmed asthma. For newly diagnosed asthma from age 12, offer a low-dose inhaled corticosteroid and formoterol combination inhaler taken when needed for symptom relief. This is anti-inflammatory reliever therapy, abbreviated to ARA. Confirm that the exact inhaler and dose are licensed for this use, and teach the maximum daily inhalations. If the person is highly symptomatic, with regular nocturnal waking for example, or presence with a severe exacerbation, start low-dose maintenance and reliever therapy called MART after treating the acute episode. The same ICS formoterol inhaler provides scheduled maintenance and symptom relief, but the prescription and action plan must clearly state both roles. If asthma is not controlled on as-needed low-dose AR, offer low-dose MART. If it remains uncontrolled, offer moderate-dose MART. Before every step up, check the diagnosis, adherence, inhaler technique, smoking or vaping, occupational and environmental exposure, rhinitis, obesity, reflux, anxiety, and other comorbidity. Escalating a medicine that never reaches the lungs is not treatment. If asthma remains uncontrolled on moderate dose MOT, despite good adherence, check FeNO if available, and blood eosinophils. Raised type 2 inflammatory markers support specialist referral. If neither is raised, the guideline allows a time-limited 8 to 1 2-week trial of a leukotriene receptor antagonist or long-acting muscarinic antagonist in addition to MART, with continuation only if benefit is demonstrated. For children aged 5 to 11, initial treatment is twice daily pediatric low-dose inhaled corticosteroid with SABA when needed. Pediatric sequencing is device, dose, and licensing specific. As of November 2025, only one budesonide formoterol dry powder inhaler strength was licensed for MART in children aged 6 to 11, so never extrapolate an adult regimen. For children under 5 who need maintenance treatment, consider an 8 to 1 2-week trial of twice daily pediatric low-dose ICS with SABA when needed. Check technique, adherence, tobacco smoke, mold, cold housing, and alternative diagnoses if there is no response. If symptoms resolve, consider stopping treatment and review after a further 3 months. Recurrent significant symptoms may justify restarting and titrating treatment. Montelukast may be considered as a trial add-on in selected young children when moderate dose ICS is insufficient. Counsel patients and carers about possible neuropsychiatric reactions, including sleep, mood, and behavioral change. And stop an ineffective trial. Assess control at every review. Ask about daytime symptoms, night waking, activity, time off work or school, reliever use, oral steroid courses, emergency attendance, and admission. Check prescription records rather than relying only on recall. A validated asthma control test may help. Routine daily peak flow monitoring is not recommended unless it serves an individual action plan. Review inhaler technique by asking the patient to demonstrate it. Match device to inspiratory ability, dexterity, and preference. For a pressurized metered dose inhaler, a spacer often improves delivery. Check mouth care after inhaled corticosteroid, local candidiasis, dysphonia, and cumulative steroid burden. Repeated oral steroid courses raise risks including diabetes, osteoporosis, infection, and adrenal suppression. Every patient should have a documented personalized asthma action plan. It should state usual treatment, the reliever and maximum use, signs of deterioration, what medicine change to make, when to request same-day review, and when to call 999. Review the plan after an attack, hospital attendance, and at least annually. When control has been stable, discuss step down rather than leaving treatment indefinitely at the highest dose. Reduce one component at a time, incorporate patient preference, and wait at least 8 to 12 weeks before another reduction. Maintain anti-inflammatory protection. From age 12, low-dose AI is an important step-down option from low-dose MART or low-dose maintenance ICS plus SABA. Now acute asthma. Assess while treating. Record speech, respiratory rate, pulse, oxygen saturation, and peak flow compared with best or predicted. Look for exhaustion, cyanosis, poor respiratory effort, altered consciousness, arrhythmia, hypotension, and a silent chest. A quiet chest in a very breathless patient is dangerous, not reassuring. In adults, acute severe asthma is present with any one of peak flow 30 to 50% of best or predicted, respiratory rate at least 25 per minute, pulse at least 110, or inability to complete sentences in one breath. Arrange hospital assessment when acute severe features persist or response is inadequate. Life-threatening asthma includes peak flow below 33%, oxygen saturation below 92%, silent chest, cyanosis, poor respiratory effort, arrhythmia, hypotension, exhaustion, or altered consciousness. A normal carbon dioxide level in a severe attack can signal respiratory failure because the expected response is a low carbon dioxide level. Arrange immediate ambulance transfer. Give oxygen when available to maintain saturation between 94 and 98%. Give repeated inhaled beta-2 agonist, preferably through a spacer when appropriate or oxygen-driven nebulizer in severe disease. Add nebulized ipratropium in severe or life-threatening asthma. Give oral prednisolone 40 to 50 milligrams promptly or intravenous hydrocortisone when oral medication cannot be taken. Do not delay transfer while waiting for full response. For community first aid with a blue reliever, the current NHS advice is 1 puff every 30 to 60 seconds, up to 10 puffs, preferably through a spacer. Call 999 if the person worsens or does not improve after the maximum dose. Air or MART inhalers have different emergency maximums, so follow the personalized plan and product-specific instructions. After an attack, arrange early follow-up, commonly within 2 working days after emergency treatment or discharge. Identify why it happened, check technique and adherence, restore inhaled corticosteroid protection, review oral steroid duration, update the action plan, and assess future risk factors. One apparently recovered attack is a warning event. Refer routinely when the diagnosis remains uncertain, occupational asthma is suspected, significant attacks recur, control remains poor despite verified adherence and technique, or biologic assessment may be needed. In preschool children, refer after a hospital admission or 2 emergency department attendances for wheeze within 12 months. A useful patient explanation is asthma causes both tightening and inflammation of the breathing tubes. The reliever opens the tubes, while the steroid component treats inflammation and reduces attack risk. That is why every treatment plan needs inhaled steroid protection, even when symptoms are intermittent. Safety net clearly. Call 999 for rapidly worsening breathlessness, inability to speak or walk normally, blue lips, drowsiness, exhaustion, a reliever that is not working or reaching the maximum action plan dose without improvement. Sit upright and do not drive yourself to hospital. For the AKT, avoid 8 traps. Do not diagnose on symptoms alone. A normal examination between episodes does not rule asthma out. Do not prescribe SABA alone. Do not step up before checking technique and adherence. Do not apply the adult AR pathway to every child. Do not overlook occupational variation. Do not interpret a silent chest as improvement. And do not discharge an attack without prompt review and an action plan. The final framework is recognize variation, confirm objectively. Provide inhaled corticosteroid protection. Check causes before stepping up. Classify an attack by the worst feature. And make technique, action planning, and follow-up part of the treatment. This has been a quick medical review webinar for the AKT section. Review the adult diagnostic thresholds and acute severe features once more, then continue to the next topic.